Welcome. My name is Dr. Jo Wilmshurst. I'm a child neurologist from Cape Town at the Red Cross Children's Hospital, and I'm going to talk to you today about our capacity to deliver epilepsy care for children with epilepsy in Africa. So, just looking at my centre alone, we're a regional referral centre, and from a survey we performed a number of years ago, we have over 2,000 children on our database that were attending our clinic at that time, and some 53% of them had epilepsy. So it was by far the major workload that we manage. When we looked at causes, 45% of them had symptomatic causes or structural causes, so related to insults that had happened to them or lesions that they were born with. And tragically, when we then broke down how many of those causes should in fact have been avoidable, it was the significant majority. Things like hypoxic ischemic encephalopathy, trauma, neuroinfections. And that is really the tragedy of epilepsy in Africa, that many of the cases that are being managed in fact should never have occurred at all. But that is the reality, and what I'm going to try and focus on today is the challenges that we have of dealing with those established cases. So in my centre, we have the capacity to access all medications, to screen the patients, to perform epilepsy surgery, and that in itself is challenging for the patients that we have. But what I wanted to understand is what's happening across the rest of Africa and what we could learn and how we could look at simple mechanisms to improve care for children. So over the last 5 years, I've been collating data from various countries, and there have been many helpful people who've provided the information that you'll be hearing about, to whom I'm most grateful. And this is an illustration of the countries who've supplied information, and many of whom have attended the epilepsy meeting that's been happening in Nairobi in June. And these people have provided information on the basic epilepsy care that's available for children in their countries. The first question I asked them was whether they had a paediatric neurology group, and in fact only a small number of the countries did. There were some 4 or 5 countries, and those that did were often part of child neurologists, where there was maybe only one child neurologist in the whole country. And my question for asking that is, if you have a national recognised group, that group can then lobby to government and often has far more lobbying power than would normally occur. My next question to them was, well, then do you have any general paediatric groups? And these numbers were greater, but were still only a small proportion of the number of countries who responded. I then asked them about entry points and referral routes for patients, and most countries admitted that it was in fact extremely difficult for patients to have any kind of consistency, that they would present to anybody from a traditional healer through to coming straight to tertiary, and that they hadn't been in a position to set up any kind of referral recommendations for these patients, so the infrastructure just wasn't in place. I asked them about guidelines for basic epilepsy care, and again only a small numbers of the countries had this, and this is very important, that the lack of having nationally accepted guidelines means that you're lobbying to government for what facilities and essential drugs must be in place will be challenged immediately. That as a single voice going to government, it's not as powerful if you have a nationally accepted guideline which all centres feel are appropriate for the care of their patients. So this was a big area that was lacking. When I asked them about initiation of medication, most places would start with phenobarbital if the patient was lucky enough to get medication and to be able to have continuity. And the other drugs were typically available on a paying basis and were not necessarily reliable for their supply. Asking about status management, again, consistency really in the early intervention, and many countries had access to phenobarbital or phenytoin. But it was the actual support and care for these patients that was hugely challenging for most centres. High care facilities were lacking, very few countries had access to syringe drivers and saturation monitors, and when asked directly, the vast majority of these countries admitted that in fact these were more in the tertiary centres, that most patients would present to the rural centres and they wouldn't actually be able to have access to this at all. And again, national guidelines not really in place. So when we pulled it all together, You know, these people were so dedicated, and the enthusiasm of wanting to improve care and wanting to find solutions is there, and the time is definitely right for moving forward and actually making some progress. Most of these countries, in fact, don't have trained individuals, and they're really asking for help, and that's at all levels, from the primary healthcare workers through to paediatric neurologists, to really build up their skills and then to make the people that you train become the trainers, to get that ripple effect going down. And very few countries, as I said, had these national guidelines that they could use to motivate for medications and facilities. Countries expressed a concern about lack of access to EEG. They were available in a few of the countries, often in psychiatry units or centres outside easy access for patients. In fact, that was a low priority in comparison to the need for training and actual recognition of seizures. Similarly, for neuroimaging, many countries had neuroimaging, but you had to pay for it, and it wasn't really a viable resource. Beyond phenobarbital, there was very little consistency of access to other agents that are available internationally. So in the management status, again, it was facility driven. That was the main problem. So in February of this year, we encouraged the people who'd been responding to come to a meeting in Uganda, and we managed to get 19 countries represented, and we went over all those issues in the questionnaire and discussed them and tried to find ways forward and to identify what the group considered were the major challenges. And from this there were many conclusions, but the main ones were clearly that training and collaboration between ourselves were important, that to encourage as part of that training the recognition and the management of epilepsy, that was clear at all levels, and to involve resources. And traditional healers are a major resource within Africa who have already been used successfully in a number of centres. That we needed to identify ideal anti-epileptic drugs that would be viable in a resource-poor setting. So previous recommendations, and certainly where concepts of essential drug lists, are based on minimum standards of care. And I think we are all moving away from that now to look at, in fact, two tiers of ideal care and optimal care. Optimal care is the reality of what happens in most resource-equipped countries, whereas resource-poor countries should give appropriate care, but it would be at an ideal level. And one of the challenges that were discussed during the meeting is phenobarbital really ideal care, and are we actually cutting ourselves short by prescribing this to children with growing and maturing brains? And in fact, should we not be lobbying for safer second-line agents with less side effects that are going to turn out stronger individuals with less comorbidities and complications from the medication? If we do that, we must ensure continuity, which is a recurring theme and a recurring problem. These guidelines, so there are international guidelines that are excellent that have been written, and we realised when we discussed it with this group that in fact many of them were not confident with the guidelines, and we needed to in fact go through these international guidelines with them to then say, would they work in Africa, are they viable, and if not, to actually start working on guidelines that will be appropriate for the African setting, that will result in ideal care that's actually viable for continuity. In conclusion, the recommendations that were drawn from these various meetings and assessments is that we really need to agree on viable guidelines that are appropriate and can work in Africa with the capacity that we have to deliver in these regions, to take the international guidelines and to convert and interpret them appropriately. We need tertiary and quaternary referral centres, at least one per country and region, for children with epilepsy to be referred through to, so that they can receive expert assessment and management guidelines to be then referred back to areas more local to where they live. We can't do that without support from the major organisations such as the WHO, the International League Against Epilepsy, IBE, the International Child Neurology Association. And they need to help us really with how we promote to governments, with the lobbying that needs to happen to really move things forward. And what comes over again and again is that need for training. that without training we can't move forward. And that training needs to be helping us training people both to recognise appropriate patients that need intervention, that need to be treated for seizures, and without having good guidelines and education and primary and secondary level, that's not going to happen.